Well, so I think we should start properly to keep in time more or less. So welcome to all of you, wherever you are in the world, for the second day of the WFNR and even our activities on the Brain Awareness Week. Brain Awareness Week is a good invention in the sense that it tries to alert the world public to the progress in brain research, to progress in our knowledge of the brain. And of course, we have to conceive the brain in different ways. You can do it from a philosophical or spiritual or scientific basis. Nevertheless, one thing is clear: there's nothing in us without the brain. And the brain, on the other hand, is a very vulnerable, soft, and tiny organ, which may need repair. And what the World Federation of Neurorehabilitation and the European Federation of Neurorehab Societies are about is to help finding ways to do some sort of brain repair when the brain has been injured by accidents or by certain diseases as stroke or degenerative diseases as Parkinson's disease and many others. So for today, we are touching on the field of pharmacological interventions in neurorehabilitation and how far the use of pharmaceuticals can or cannot be helpful and may eventually even be deleterious if we use them. So let's start immediately. Christian, if you could start my video. It's my pleasure to do that jointly, of course, with Professor David Moregiano, who is the president of the European Federation of Neurorehabilitation. He will talk later on and go a little bit deeper into the philosophy of the pharmaceutical intervention. So we start with my talk first, which gives you a sort of a survey view on where we are in this field at the moment. Christian, press the button.
So welcome to all of you to the second day of the WFNR webinars within the Brain Awareness Week. We very much like to support the Brain Awareness Week, alerting the world to the enormous impact of brain health on the future of mankind, and we feel that we can contribute to some extent in the field of neurorehabilitation to improve, repair the brain whenever it's necessary. What we're going to address today is in how much pharmacological interactions, drugs if you like, may help to ease brain repair, and we will very much concentrate on that. Again, we are doing that jointly with our friends from AMN, SSNN, and especially with the European Federation of Neurorehabilitation Societies, and my co-chairman, Professor David Moregiano, is the president of EFNR. This is some suggested reading for you. It's open access and will give you more or less comprehensive review on the topic. Let's start with general pharmacology of data derived primarily from animal experimentation as to which substances may be helpful or may be bad or disastrous even for plasticity after acute cerebral injury. Let's look at the effect of amphetamines. For instance, by and large, amphetamines in animal experimentation can improve recovery of motor, perceptual, and cognitive function in animal experimentation. This effect usually can be antagonized by butyrophenones, for instance. Let's look at the effect of symptotomimetics. You all know that methylphenidate is widely used in the treatment of attention deficit disorders. In animal experimentation, methylphenidate has only transient effects on brain recovery. Alpha-2 antagonists such as yohimbine and adaxazone increase central noradrenaline release and facilitate recovery, whereas alpha-2 agonists as clonidine, which is a frequently used antihypertensive drug, impair recovery, as do alpha-1 antagonists as prazosin, also used as an antihypertensive agent. Phentermine and phenylpropolamine have similar effects as amphetamines, and the very frequently used beta blockers, as propranolol and the more modern ones, have no effect on recovery. Butyrophenones, frequently used as sedative drugs and antipsychotic drugs, have a very bad effect on recovery, whereas tricyclic antidepressants have only neutral or mildly negative effects on recovery. When we look at GABAergic substances, it's clear that local GABA administration at cortical lesions impairs recovery. And what is very important to know, benzodiazepines, very potent GABA agonists, definitely impair recovery in an almost disastrous way. Anti-epileptics is a very important issue, of course. From animal experimentation for a long time, it's known that phenytoin has definitely negative effects, probably by GABAergic mechanisms, as have barbiturates, as phenobarb, for instance, and whereas carbamazepine, also still frequently used as an anti-epileptic, has no influence on recovery as far as we know. Looking at cholinergic substances, cholinergics increase the speed of recovery, and scopolamine, an anticholinergic agent, does the opposite, impairs recovery in experimental settings. There's a very important concept of detrimental drugs. Detrimental drugs are those which should be avoided in the period of brain recovery in the immediate acute and post-acute phase of the brain lesions, because they have known negative effects on brain plasticity, reorganization, and learning. A list of the most important detrimental drugs which, whenever possible, should be avoided in this period after brain injury. That includes butyrophenones as haloperidol, prazosin and clonidine as antihypertensives, phenytoin and benzodiazepines as anticonvulsants and sedatives. And let's now look at the key question of how brain recovery can be promoted by pharmacological agents. In the acute and subacute phase after lesions, we will address that, both for stroke as well as for traumatic brain injury. Considering this, we have to keep in mind that a plethora of different molecular mechanisms is going on after an acute brain lesion. We have a lot of mechanisms such as excitotoxicity, apoptosis. On one hand, we have sprouting of synapses. On the other side, we have at least 4 different terms describing what can be done about that, going from neurotrophicity, increasing neural regrowth, via neuroprotection, providing sort of a protection shield for these mechanisms, and those drugs which may influence neuroplasticity in the strict sense, and finally also de novo neurogenesis. Well, to cut a long story short, so far we have only 2 substances in which bigger randomized controlled trials have shown some efficacy in decreasing impairment in combination with physiotherapy in the immediate post-acute phase after stroke. This is the famous FLAME trial run by François Choulet and his colleagues in France. They looked at about 120 patients, randomly assigned to 2 groups, one receiving fluoxetine, one receiving placebo in the immediate post-acute phase after stroke. And the net result, when you just look at the modified Ranting scale, which is a pretty crude and not very fine measure of functional recovery after brain injury, the authors found that there was a significant effect of fluoxetine in this period. So has this been corroborated? Basically not. There was the TALOS trial in 2017 looking at citalopram, another serotonin reuptake inhibitor, as fluoxetine is, also in post-acute stroke patients. A total of 642 patients were collected and they looked at an early 6-month follow-up after stroke. And by and large, there was a little tendency of the citalopram being superior to controls, but more or less the trial was neutral when you just look at the modified Ranting scale. Recently, another study, the FOCUS trial on fluoxetine, was published, and indeed the effect again was neutral. So at the end of the day, we actually do not know if serotonin reuptake inhibitors or other antidepressants definitely do improve functional recovery. They definitely improve depression after stroke, but the other question is, do they in addition something to increase brain reorganization? And the answer is open. There is conflicting evidence. It's different with cerebrolysine. Cerebrolysine is a pluripotent drug. It's a weird cocktail of neurotrophic factors administered non-orally, usually by IV or an injection. And we conducted the bigger trial, the CARS trial, some years ago, and looking as the primary outcome variable was a complex function test for the upper extremity. And it was a very surprising, robust finding to find that in the ARIT, the action research arm test, on the pratic side, within a month and up to 3 months, which was the final endpoint, there was a clear beneficial effect of cerebrolysine. And most of the parameters looked at, when you look at this forest plot, you see there's an overall combined effect, but there are also significant effects on the ARIT, for instance, on gait velocity and other parameters. The question is has there been corroboration for these initial findings in the first CARS trial? In actual fact, there was. We conducted several later trials and meta-analysis using cerebrolysine and looking at the effect of motor function recovery in combination with physiotherapy. And the overall effect, as you can see, again, is similar to the CARS-1 trial. The CARS-2 trial, though, as we enrolled less severely affected patients, didn't show as clear effects as the first CARS trial did.
Well, to clarify further the possible role of pharmacological supports in early motor rehabilitation, we set up a working group under the auspices of the European Academy of Neurology to come up with a high-quality guideline in this respect. You can see the authors. It was a painstaking, long-going process. This is just a glimpse on the final results. At the end of the day, we came up with a recommendation for clinical use for only 2 substances, which was cerebrolysine and citalopram at a dose of 20 milligrams a day. And we also made some comments against clinical use for quite a bunch of substances, including citalopram at lower doses and amphetamines. Professor Morigiano will go into much more detail with the parameters and factors influencing this study later on. Okay, let's now look at what options we have for brain recovery promotion in traumatic brain injury. For a long time, pharmacological interventions in TBI most of the trials were neutral or even negative. And the question was, is this due to the wrong drug? Or is this due to wrong assessment and possibly selecting the wrong endpoints and looking to the entire problem from the wrong perspective? In this respect, we tried what I would like to call a double multi-solution. You will see in a minute what I mean by that. This was one of the first papers we published about new methodological issues on looking at pharmacological interactions after acute brain injury and their neurorecovery with a new design and new methods. And this new design is primarily due to the fact that we tried to use a multidimensional ensemble of outcome scales rather than just using the Glasgow outcome scale, for instance, or the Glasgow coma scale as the only endpoint determining the result of a possible intervention. That is multi number 1. And multi number 2 is that we decided, similar to the work in stroke, to use a multimodal drug, namely cerebrolysine, for this intervention. So the first trial we did was with friends in the Asian and Southern Pacific region, the CAPTAIN-1 trial.
And this was published some years ago. And looking at the baseline characteristics of the cervicalicin versus the placebo group, it was a small sample of patients, and you can see that the in both groups, cervicalicin and placebo, the baseline data were really very well comparable. We used, as I mentioned, a real multidimensional ensemble of parameters. All of these parameters can be analyzed separately, but they can be put together by a clever multivariate statistics into one Weyl-Lakin analysis, as we call it, outcome ensemble. And you see the ensemble includes group measures as the Glasgow Outcome Scale or the Early Rehabilitation Bartel Index, indicators of cognitive behavior as the mini-mental status examination, more detailed tests looking at processing speed, on distraction, on memory aspects, and on dexterity and movement speed, as well as parameters related to the emotional outcome, looking at anxiety and depression with the Hamilton Anxiety and Depression Scale. So altogether 14 ensemble data which can be put together to get a grasp if there is going on anything in this respect with a pharmacological intervention. Okay, and the results were pretty convincing. You see the forest plot here for this multidimensional ensemble for the protocol analysis at day 30, and you see there is an overall significant effect favoring the active treatment with IV cervicalicin, also in the composite analysis. And this is also the case at day 90, which was the definite final endpoint in this protocol analysis of the first CAPTAIN trial. So there is at least a signal that this drug works when you look at the outcome from a multidimensional perspective. We decided after that to do a bigger CAPTAIN trial, 2 trial, primarily in Romania. See the authors again. And looking at we changed the protocol to some extent. The time to needle in the CAPTAIN 2 trial was an average 2 hours earlier for the first injection compared to CAPTAIN 1. And we added a third obligatory treatment cycle for all patients in the CAPTAIN 2 trial. And this is again the data of the multidimensional ensemble for the intention to treat analysis at day 30 in this trial. And again, you see that corroborating what you'd seen already in the CAPTAIN 1 trial, there was an overall significant effect in most of the parameters looked at. This is also true for the ensemble data at day 90 in the intention to treat analysis. Here again, an overall positive effect, more than just a signal, a really significant effect of the intervention on the variety of data, including motor, cognitive, and general scores of ability and outcome. We also did a meta-analysis in comparing the CAPTAIN 1 and CAPTAIN 2 trials. And this is the overall result from the meta-analysis. You see the forest plot here. And whatever statistical analysis you use, there is an overall significant corroboration of the effect of both trials. This also holds true in the ITT analysis at day 90. A very important issue is what drugs can be used to enhance arousal in patients with diminished states of consciousness. A lot of so-called CNS stimulants have been used as methylphenidate, for instance, which has shown marginally positive effects. Dopaminergics have also been used as levodopa and amantadine, and there were various effects in smaller observational trials. And antidepressants and amitriptyline have also shown effects. The only really bigger trial was published some years ago in the New England Journal and looked at amantadine in patients with diminished state of consciousness, and there was an overall positive effect of amantadine when applied for a couple of weeks after the injury. It's interesting to know that there are effects of CNS depressants on the on arousal promotion. Important is that Z-drugs, as zolpidem, in some patients may have positive effects in waking them up, although the Z-drugs basically are CNE depressants. But it's worth trying, sometimes even after a single dose of a Z-drug. The patients may suddenly improve in terms of their cognitive abilities and also in their level of consciousness. So it's always worth trying. A big issue, of course, is neuroaugmentation. What pharmacological agents can be used to improve certain elements of behavior, for instance, cognitive abilities or motor abilities. Let's look at the cholinergic system. You know, the cholinergic system originating from the basal forebrain nuclei is spreading all over the neocortex. And the cholinergic system certainly stimulates areas related to learning and memory. That gave rise to the question, can cholinergics be used as neurochemical basis for cognitive deficits? In, for instance, Parkinson's disease, in other degenerative diseases as supranuclear palsy and Alzheimer's disease and various vascular diseases, tumors, and also TBI. Well, cholinomimetics such as the napacil and rivastigmine are frequently used in mild to moderate forms of dementias, almost on a day-by-day basis in many countries. It's a small effect, but it's definitely a present effect. The question was, do nicotine patches, for instance, nicotine is, of course, stimulating nicotinic acetylcholine receptors. Does nicotine, for instance, provided as a patch, help Alzheimer's disease? This study was negative. There was another study also showing no evidence.
Okay, let's next look at noradrenergic projections. You know, they are originating from brainstem nuclei, especially nucleus ceruleus and others, and also have a widespread innervation of the neocortex. Amphetamines are noradrenergic drugs primarily, and the question is, are amphetamines helpful to ease recovery? And Danfini, back in the early 80s, did journal experiments looking at the effect of amphetamine administration in combination with some sort of treatment or physiotherapy, if you like, in kittens and also rodents. And he showed that in actual fact, amphetamine really eases recovery, giving rise to a fast recovery after experimental lesions, which can be completely antagonized by haloperidol, for instance. Later on, experimenters, Katrin Butefisch as an example of that, looked at the impact of amphetamine on learning in normal, hopefully normal college students with positive results in complex finger-thumb interaction tasks, for instance. And my friend Dinze, early in the July 2003, also showed that the administration of amphetamine eases two-point discrimination learning. The first trial on looking for some evidence if amphetamine in combination with physical therapy may promote recovery also in human stroke patients was by Chrysostomo. And in this paper, they looked at only 8 patients with more or less mixed results, but nevertheless, that paper started some enthusiasm on possible use of amphetamines to ease recovery after stroke. The bottom line so far, although a couple of other studies have been done since, is that there is no clear-cut evidence that amphetamines unequivocally improve functional outcomes in subacute brain injuries. Reboxetine is a selective noradrenaline reuptake inhibitor, having somewhat nicer features compared to amphetamines, less side effects. Reboxetine is listed for the treatment of major depression or depression in Parkinson's disease. And in actual fact, authors have shown that motor cortical excitability in normal volunteers can be upregulated by the use of reboxetine. And Zittel and others a couple of years ago did a first pilot study on reboxetine improvement of motor function in chronic stroke, and in actual fact they found good results concerning grip strength, tapping, and other parameters they looked at with the administration of reboxetine. So reboxetine is an interesting target drug for further use. Let's also look at dopaminergic projections. This is from Redbrand again. You know, they originate primarily from the Raphe nuclei in the brain stem and also have a widespread distribution into the basal ganglia and the neocortex. Klaus Scheidmann, a couple of years ago, looked at the effect of levodopa in combination again with physiotherapy on functional recovery after stroke. We have to note that dopamine or dopaminergics, as most of the dopamine-containing drugs, are dirty drugs in the sense that they are not just attacking dopamine receptors, they have a partial binding also to noradrenaline receptors, so it is never clear if these are really dopaminergic effects. What Scheidmann and colleagues found, however, was with an administration of 100 milligrams levodopa a day in the post-acute phase after stroke, that there was indeed an improvement in the rate of recovery of patients receiving levodopa in this study. Let's take a moment with the interesting effect of dopamine agents on neglect. This was first published in the late 1980s by the group of Ken Heilman, who found in some few patients that the application of a dopamine agonist as bromocriptine over a couple of weeks could have beneficial effect in neglect patients. And there were several studies going on, smaller studies going on later on. This is by Dimignani and colleagues from 1998, who looked at 4 patients with left-sided neglect and also after dopaminergic stimulation found a positive effect. There is one bigger randomized controlled trial done in London 10 years ago, and they used a crossover design looking at patients with posterior or anterior located right hemispheric lesions, and they used rotigotine, a transdermal application for OVD2 agonist, and by and large found very beneficial result. This is a heat plot just projected on a search task that after the rotigotine, with rotigotine on, there was a much better neglect behavior than without the rotigotine. And they looked at 16 right hemisphere stroke patients, and all of whom completed the trial. And the performance was that on shape cancellation task, the mesoderm shape cancellation task, the patients improved significantly under the rotigotine. This was a trial without a control group. There was an AB design in the sense that every patient was his or her own control. Of course, the neurochemistry of visual attention is a very interesting topic in general, giving us some hints how eventually dopaminergics will work on neglect. This is a recommendable paper published recently in Frontiers in Neuroscience. And also a very important paper is this one, Control of Visual Cortical Signals by Prefrontal Dopamine in Animal Experimentation by Nudost and others. And they did an intriguing experiment in the sense that they looked at monkeys and they injected in the frontal eye fields dopaminergic agents and looked at the corresponding
V4 areas corresponding in terms of that they have the same receptive fields, that after the administration of a dopaminergic, the cortical response in V4, which is, as you know, primarily related in aspects of color vision, for instance, was significantly earlier and increased in size. So in summary, when it comes to dopaminergics, there is slight evidence of improving motor and language function after stroke, and there's sporadic evidence for improving level of consciousness. And let's further look at aspects of depression and on antidepressant agents. Post-stroke depression is a fairly frequent problem, attacking 50 and 6% of patients. And it is known from a lot of work that early treatment may improve rehabilitation outcome. Early treatment may result in improved cognition, and early treatment started within the first 12 weeks after stroke increases the probability of survival in depressed and non-depressed patients, which is an interesting phenomenon. And only early treatment seems to lead to cognitive improvement. So there seems to be a critical time window for the treatment of depression. This is this work from Jorge showing that the survival rate over 9-year follow-up of acute stroke patient who received a 12-week post-stroke course of antidepressants was much more favorable than those not receiving antidepressants in the placebo group. The reason for that is not entirely clear.
Depression also is a frequent feature in patients with multiple sclerosis, with a lifetime prevalence of around 50%. And we have to keep in mind that the suicidal risk of MS patients almost double that of the normal population. And by and large, depression in MS is not sufficiently treated. Another frequent problem in multiple sclerosis is fatigue. 50 to 90% of MS patients have fatigue problems. This fatigue is often associated with temperature sensitivity. It is, however, not clearly correlated with depression, and it may at times be difficult in an individual patient to differentiate between central and peripheral aspects of fatigue. Treatment options. Amantadine has been shown to be helpful, pamelaine, and especially modafinil, which is primarily used for the treatment of parasomnic disorders, can be used. In actual fact, modafinil for a couple of years was listed for the treatment of fatigue in MS patients in Germany, and unfortunately that was dropped a couple of years ago. Nevertheless, also in our hands, modafinil is a really good tool to use it in fatigue patients. What we do not know yet, and there are no studies available at the moment, in how far long COVID fatigue problems can also be assessed by modafinil, for instance. So let's draw some general conclusions. Pharmacological support of neurorehabilitation is a valid concept, but some important key aspects should be considered. First of all, we need a correct strategy integrating acute and long-term pharmacological treatments. So far, the use of neuroenhancers cannot be recommended outside clinical trials. And drugs known to have plasticity decreasing properties, called detrimental drugs, should be avoided whenever possible. The use of antidepressants definitely can be recommended also in non-depressed patients in the subacute phase after stroke, and the role of multimodal substances such as cerebrolysine appears promising. Okay, this is all I wanted to say for today. I just want to alert you to two meetings coming up. One is the European Congress of Neurorehabilitation in Lyon in late summer this year, August, September, and the forthcoming World Congress of Neurorehabilitation in Vancouver, Canada, probably in late May 2024. So many thanks for your kind attention, and of course I'm happy to answer comments and questions. If this is not possible in person on this meeting, just drop me an email. I'm happy to answer your requests. Many thanks.
Okay, that was it for my talk. Let me have a look at the chat room. As far as I can see, there are no question and answers yet. Well, to the audience, it's certainly a good idea if you ask questions. Do not hesitate to do so. The more, the more you can learn. And of course, we are very happy to answer these questions right on the spot. Let me ask the panel, Daphne and Stephanie is with us on the panel. Are there any questions or comments?
Thank you very much, Volker. Great talk. Stephanie, please, if you would like to ask something, then I will follow you.
Okay. Well, we are talking more and more, even in neurorehabilitation, about personalized approaches and about precision medicine. What would this mean for pharmacotherapy in neurorehabilitation?
Well, that's a good question, Stephanie. Of course, we're all hitting on this aspect of personal individualized medicine. We have some, let's say, genetic determinants, for instance, for the use of antidepressants in depression. We don't have that for the application in neurorehabilitation circumstances as improving brain recovery, for instance, at all. That is a completely dark field. Yeah. And it certainly needs further consideration. On the other side, I think that when you look at real game changers in all fields, usually pharmacological aspects are predominant. They're probably more eminent than what we do in training strategies and behavioral interventions in neurorehab. So I think that following the pharmacological aspects further with a better teleological design of drugs and a better physiological understanding of what you're doing with pharmacological intervention will bring us probably a bit forward compared to other interventions. But we are lacking basically all evidence of personalization of pharmacological interventions so far. But that is a certain important target for future research in the field. So let me see. Any other nice?
May I, Volker?
Yeah, sure, Daphne.
Yes. So thank you, Stephanie, for your absolutely valuable question. What I would like to comment is that for sure we have some very good hopes, and I believe that our most important hope is related to pharmacological interventions. This is very stable. We have learned a lot out of, I would say, out of our experience in the last 40, 50 years. Overall, mostly if we look at the last 20 years, we have learned many lessons. I think we have some hope in other types of intervention, in those who are, let's say, labeled as non-pharmacological intervention. We may have some hope. And I think the challenge is to refine and to focus more on whatever intervention we have, to focus more in these biomarkers. And definitely, I think the answers will come from the new methodologies, stratifying better patients and evaluating the biological reserve. I think that your question regarding personalized aspects are very much related to personalize the evaluation of endogenous defense mechanism and the biological reserve. I think here is the big difference. We have such a huge heterogeneity in different persons when we look into the potential of recovery. So in this respect, I think we can do a lot, and the good compromise between our needs towards evidence-based medicine and our needs to personalize may be navigated in these, I would say, shallow waters, but somehow promising waters of stratifying, at least in a better way, those who have the chance to recover better based on a good biological reserve, and those who are not so prone to recovery. And when we issue judgment about an intervention, we should be very careful and to be sure that the intervention was tested on those populations with good potential for recovery, because otherwise we'll label as non-efficient many interventions that are maybe good, but we don't have the capacity to individualize somehow, even in a very primitive way, let's say, not in the best way, but even in this I would say better way. And I think we may play around these targets, and biological reserve may bring us a better approach.
Okay, thank you very much, Daphne. I think if there are no further comments, we will go on. It's my delicate pleasure and honor to introduce my co-chairman, Professor Daphne Moregiano, as the next speaker. I'm extremely grateful because today this is Daphne's birthday, and nevertheless, he agreed to join us on this conference this afternoon. And we look forward, he is one of the certain of the pioneers of using brain repair promoting drugs in the field, and has enormous contributions to this field. And I think he is probably going to talk about that in more depth than I did, especially also looking at the brain reserve aspects and other aspects. So Daphne, thank you very much for joining us today, and we look forward to your talk.
Thank you very much. Thank you.
So what we have to keep in mind always as medical doctors is that we have three important pillars to contemplate all the time. But whatever we'll do in our efforts to develop the science and practice, not only of neurorehab, but as I mentioned, brain protection and recovery, is to start always from theory and basic research. We have to develop a strong theory and to check the hypothesis and to validate at the end by basic research the important ideas that then should be, and data that then should be translated and tested in the paradigm of evidence-based. Then, as we know that not everything what is evidence-based is applicable to real world, we have to see to what extent this data is applicable and to test the effectiveness of our interventions. And this is based on, strong clinical experience. So whatever we'll do will be in this triangle, and this is important. Just to mention quickly that rehabilitation, and I would say the rehabilitation is not only a process and a practice, it's getting more and more a very strong science today. In order to reach back this maximum physical, functional, cognitive, psychosocial recovery, you have always to consider the two very important aspects that will determine that. It's the limit of the disability and the individual biological reserve. So it's very much the outcome depends a lot about the lesion and about the biological reserve of individual person. And we cannot go any further from this I would say, paradigm. That is extremely important. So let's go back to science. I will always remember, and I will always like to highlight and to underline how important it is to understand the post-lesional brain regulation. And this is different than we believed a few years ago. In every important scientific meeting, I'm bringing this into the attention. And today we know that after a lesion, there is always an endogenous brain defense response consisting of two sequences. And these two sequences are anti-correlated. And we have to keep in mind that the sequence of protection, which is an immediate sequence, is actually a short-term oriented sequence and a mild one. So its contribution to the overall recovery is rather modest. Then a longer and more robust sequence is the sequence of repair, which will definitely support recovery on the long-term run. It's important to understand that when protection, endogenous protection is active, recovery capacity is almost zero, and the other way around. So there is a balance, it's an anti-correlation. This is about lesion. We try enormously in the last 30 years to demonstrate neuroprotective effect for many interventions. This innate endogenous capacity, it's limited, so we shouldn't pedal on this paradigm too much, but rather to boost the second sequence, to take advantage of protection, which is very important, you will see, particularly vascular protection is important, but then at least to do this without jeopardizing the capacity of plasticity. And we have learned the hard lesson that these pathophysiological mechanisms are not enemies, and these should not be suppressed, because whenever we try to block, for example, the effect of glutamate on the short-term run, but we'll not be able to do it as short as protection is active. And usually we block to a larger extent, and then we'll jeopardize the robust and strong process that will really contribute to brain recovery. That is very interesting. I told you about the pharmacological interventions. I told you about the endogenous machinery, about the need to rebalance endogenous machinery in order to get recovery, and the limitations of pharmacological interventions so far. So the limitation of pharmacological intervention related to brain protection and recovery are directly related to the pattern of brain function. How brain does to endogenous machinery. Short-term oriented, weak sequence of protection, long-term oriented, robust sequence of recovery, anti-correlated. So in this table you have the general conclusions regarding this approach. And you have also the theoretical background. So we have a classic approach with the chemical drugs, so-called monomodal drugs, which are, let's say, embedded into this picture, and we have always to consider the damage mechanism in the classic approach. In the classic approach, the damage mechanism is a linear sum of independent events, excitotoxicity, inflammation, that can be maybe managed somehow independently. And then endogenous defense activity was not perceived as an integrated process. It was perceived as two sequences that maybe overlap, protection and recovery. It was no knowledge regarding the anti-correlation. So the idea was that you may block it whenever you like, or you may stimulate it whenever you like, whatever sequence. Actually, the pharmacological strategy for protection in this respect was the simple strategy to suppress cascades and pathophysiological processes. Then the pharmacological strategies for regeneration, it was the simple strategy to stimulate whenever you like. And then, why not to use the monomodal molecules with a single mechanism? Single mechanism is not necessarily about a single pharmacological mechanism. A monomodal drug may do a lot of effects, but still controlling only one part of endogenous biological sequence, the sequence of protection or the sequence of recovery. That is the monomodality. Multimodality is not about doing many things, but doing as brain does, both in an entangled way. So therefore, monomodal molecules were perceived in the classic approach as being okay. But when we did all the clinical trials, 20 years, all clinical trials failed in demonstrating efficacy. And then, you know, the paradigm in which those molecules have been tested was the short-term oriented paradigm. If we look into the mirror with the current knowledge that we have got, we are not using the linear pathway theory, we are using the dynamic network theory, including all our vision about brain, all these three levels, how brain function. We know that the damage mechanism, it's a non-linear imbalance. It's actually an entangled process. It's a very complex process. It's an imbalance of normal processes. And this should be rebalanced, not suppressed, should be modulated. Then endogenous defense activity is not just a simple add between protection and recovery, but there is an intrinsic relation. You cannot block glutamate without having effects on the long-term run on the recovery. So the damage mechanism is not a continuous, it's a continuous process, it's not a disrupted sequence. And the sequences are not separable, because in the classic concept, the sequences were separable. And then the pharmacological strategy for protection will not be the suppressive or stimulating strategy, but will be the integrated strategy of remodulating the whole aspects. And will not use monomodal molecules, but will use multimodal molecules, doing like brain does, combining these two sequences exactly in a biological way. And therefore, the strategy of treatment would be long-term oriented. So in this way, with the multimodal drugs, we may achieve a mild, immediate neuroprotection, but this is not relevant as long as we cannot activate without disturbing endogenous processes of regeneration. And a multimodal drug will be able, a monomodal will just stay that, and eventually disturbing this by blocking glutamate and other resources. But doing in an integrated way, we may follow the sequence of the brain. Now, the current classification, therefore, after explaining you all these aspects, is that we may have suppressive drugs, suppressing, as in the past, we are still pedaling on some paradigms of creating neuroprotection, also in stroke, but we failed. The last relevant, important clinical trials for neuroprotection in acute stroke was with NA1, a super selective blocker of extrasynaptic glutamate pathway that failed. And then stimulating drugs, they provided some effects because we need to stimulate something at a later time point, but with huge cost. The cost would be adverse events. But if we'll use the multimodal drugs, we'll see that the evidence base, it's now ready to provide good data because some relevant clinical trials have been developed. Regarding this monomodal pleiotropic drug stimulating plasticity, you have heard about fluoxetine and amphetamine and dopa, I just listed it. Of course, we had the FLAME study with fluoxetine was positive, but then the other studies didn't prove that. We have now the other SSRI studies, but we still, as a general conclusion, we may use these pleiotropic drugs, still monomodal, because they are just stimulating somehow different loops of regeneration, including by and large plasticity, and we may let's say add in top of spontaneous recovery something. Regarding the multimodal drugs, and the concept of multimodality was very timid at the beginning. This was not very long time ago, 2006 when was really coined. And this was a very important paper sending the message that we have to use a multimodal approach, and drugs with trophic and regenerative effects might be useful in the future. But what we have today in the top of SSRI, the only robust evidence that we have is based on neurotrophic factors. And this cocktail of trophic factors, let's say combination of different active fragments of trophic factor, this is the definition of this intervention. It's not by chance, because there are particular active fragments, the fragments that are fixing the receptors, precisely fixing the receptors of the trophic factors, well defined. And you have here CNTF, GDNF, IGF-1, so active fragments of these peptides that are activating receptors. And you know, the mistake was that in the past, this intervention, which is mostly long-term oriented, this intervention was used with the wrong design. We discussed at the beginning what contribution might have basic research to pick up the right intervention. What contribution might have evidence-based to develop data. But we cannot bring good data, we cannot generate data if we'll take a good intervention and we'll use it with the wrong design. So therefore, taking an intervention which is long-term based mechanism and using in a protection paradigm, that was rather a limitation, that the limitation was according to the knowledge that we had at that time. So acute stroke studies of single interventions with the trophic factors, with cerebralizing, have been able to prove something, even 20 years ago. But not to that extent as we did when we changed the paradigm and we went for long-term oriented treatment. And when we add, as an add-on intervention, neurorehab, so the synergistic approach, and this tremendously increased the chances for recovery. And the validity of the concept is proved also when we start as early as possible, and also when we start a little bit later. And when we start a little bit later, we still have the chance to detect results for the very simple reason that the recovery process is long-term oriented. It's not short-term oriented. And we'll still hold some chances to detect results. And who tells us this? These clinical trials. So the all protection clinical trials tells us, guys, even if you do something short-term oriented, you may benefit. But you will lose the power of the intervention. But when you start early and you continue long-term, then you really have a capacity to influence. And if we add rehab, it's even better. When you start late, it's still a good chance. And this is the E-Compass study which tells us this, and the CARS study concept, CARS studies concept tells us that long-term administration, early start, combination treatment with rehab will definitely give better chances. So this large randomized control trial, one of the largest randomized control in early rehab, motor rehab in stroke, and published by an international group conducted by us and published in Stroke late 2016, early 17, proved that the double intervention using cerebralizing with a window, with a therapeutic window of 24 to 72 hours, combined with rehab with a therapeutic window of 48 to 72. So we have respected the guidelines, the American guideline, telling us that basically you should not initiate recovery as a general statement in the 24 hours, which may be or may not be according to the patient condition. But being in a rehab study, we have respected that. So having this intervention and administrating 21 days, so longer term treatment, pharmacological support, and having as a primary objective the change in baseline ARAT score at 90 days, and some other valuable secondary objectives, we have been able to detect efficacy parameters and also to reconfirm an excellent safety profile. So using the ARAT, I will not insist on ARAT, and having very balanced groups with a large number for rehab study, 208 patients, and you will have that we'll get more by adding the CARS2. Very balanced in respect to, you know, to the homogeneity somehow of ARAT paretic, NIHSS, Bartel, modifier ranking, and so on and so forth. We have been able to detect a consistent change from baseline in ARAT with 32 points in the double intervention group versus 11 points here, which if we'll measure in a very, and we'll describe in a very, I would say, systematic statistic parameters, we'll see that at the end point we have a large effect. We have a large superiority of our double intervention, but the message is even better because we can even detect significant effects at 14 days. And this is very important because at 14 days you are still in a vulnerable period after stroke, and we as neurologists, we are very much concerned about the potential complications after stroke in the acute stroke. So therefore, by moving a bit better the patient, we may reduce this, you know, potential threats of an acute stroke patient, and even somehow to indirectly influence the cognitive capacity and the depression, because a patient who will be able to move will be, I mean, you know, contextual, less depressed. Not to mention the real molecular mechanism of the effect of trophic factors on depression. So therefore, in respect to modifier ranking scale, you know, in the double intervention, 42.3 versus 14.9, in the let's say only rehab treated group, and the multivariate analysis pointed towards robust effect in combining these interventions in the double intervention, and you may see that we have real robust, clear effects without crossing the zero line here, in at least in primary endpoint, in ARAT, NIHSS, Bartel, modifier ranking scale, you know, this quality of life scales, and depression here. So this is a clear, good, optimistic and solid base. And if you look into the safety profile, you will see that the safety profile, it's almost equal to placebo. And if we'll add into this picture the second CARS trial that was performed on the milder population, so less severely affected population in respect to NIHSS baseline, we'll see that, you know, here doesn't matter if we add or subtract the very controversial part of ARAT 0, because we just want to prove that with ARAT 0 scores, this is a long story, I don't want to make it now, with or without, we may have the same detectable good effect somehow, and we have to insist on the concept of early benefit measured at 14 and 21 days. And this early benefit is detectable and measurable using NIHSS scale at 14 days and as well as 21 days. So the early benefit is there. Of course, NIHSS measures severity. It's not an outcome scale, but still, it is used to describe the evolution of the outcome of the patient in the immediate, in the acute and subacute phases. Now, we have also a large meta-analysis, a very large meta-analysis elaborated by this group, and Professor Nathan Borstein was the coordinator. And this meta-analysis was taking in consideration 9 very important ischemic stroke trials with trophic factors, with cerebralizing. And you may see that if you look into the 30 days, keeping on with the early benefit, we'll see that cerebralizing versus placebo at 30 days, it's completely in the favor of the pharmacological intervention. And if you look into the number needed to treat, which is a fantastic, important, clinical relevant parameters, tell me, what is the number needed to treat for, let's say, you may choose whatever, let's say, antiplatelet. The number needed to treat is rather high, sometimes 200 patients. But look at the number needed to treat here. You know, the results of this very diligently performed meta-analysis, it took us to this number, 7.7, which is a very important one. So I think we have to look into the clinical relevance and the concept. And if we look particularly in the moderate, severe category of patients, we'll see that the effect is even higher. It's higher, and it's even higher. And if you look also into this NIHSS above 12, it's even better. And to make the long story short, if we look at the safety profile, here you may see that the safety profile, it's there. Also, if we'll add and pull all these studies, and definitely have a better significance. But the safety profile, it's absolutely excellent. Now, I will close my talk with a hint related to the mechanism of action, because we know today in neurorehab we talk a lot about compensation versus restoration. And any intervention should be assessed in this respect. How much compensation will generate? If it's only compensation, or if it's adding really to the neurorestoration part. So if you look into this eCompass study, which actually use more or less the same protocol of treatment, but initiating the treatment after 7 days, you will see that if we'll look into the connectivity of the brain before and after treatment, in the group treated with a single intervention and in the group treated with double intervention, we'll see that in the double intervention group, we have a very robust recovery signal. We have the rebalance. We may notice that the rebalance and the laterality index is coming back. But in the single intervention treated group, we may see that this laterality imbalance still persists even after 90 days. So the idea of having a double intervention and the support of neuropharmacological agent, a valid one, doing as brain does, not disturbing the long process of recovery, because all acute-based suppressive monomodal intervention, the first drawback was related to the capacity to block for mid and long term glutamate activity, inflammation, and many other pathways that they have also a very good phase. So we have to understand that the paradigm changes, and the better we understand the complexity of brain function, we understand that we have to be knowledgeable, then we have to learn more about brain function, that the early rehabilitation is very important but should be performed in a very organized way, and those who are doing that should understand all the details of brain function. And I think if we'll carry on with this message, we'll be able to add something in top of further development. Now let's have a diligent look into this European Academy of Neurology and European Federation of Neurorehabilitation Society guideline dedicated to early motor neurorehabilitation after acute ischemic stroke, which is a very sensitive matter, as I mentioned before. So this is the final paper, and of course this is the task force that worked hard 3 years or even more in order to bring clarity into the topic and to put together all data or components of this very complex guideline. So as a conclusion, after very long analysis and diligent work, we have recommendation for clinical use for 2 molecules, cerebralizing 30 ml per day intravenously, minimum 10 days, and citalopram 20 milligrams per day, which is an oral component, both of them with weak recommendation. But just to remind you the correspondence between grade and the classic system for guidelines is that a weak recommendation, it's a level 2 recommendation for classic level of evidence. We have a recommendation against for the other molecules, and somehow this brings clarity for the moment. Thank you very much for your kind attention, and I hope that now we have better clarity in order to offer our support to our patients in a more diligent way.
Okay, Daphne, thank you very much for this very, very clear presentation. Also going into more depth concerning the various aspects of composition of possible substances which can be used and how they blend into pathophysiological problems after stroke. Let me look if there are questions from the floor. This is at the moment not really the case. Well, let me briefly address the issue of guideline production. We know, and you mentioned that for good reasons, that is a very painstaking process and takes a long time, especially if you do that considering the length of time needed. It's always difficult to let's say, come to an aggiornamento from year to year of the guidelines. So the question is, are there not better means of structuring the available information, also using artificial intelligence, for instance, to come to a, let's say, faster rejuvenation of these guidelines?
Yes, I believe your question is one of the most relevant, and I think this is our most active concern today. How can we keep the pace of the real acquisition of data, clinical data, and this very needful, I would say, aggiornamento, as you define it very nicely. Yes, because we have to align permanently. It's a pity to stay behind of all these data that are accumulating at a fast pace. I think the artificial intelligence will get a fabulous role in this respect, as this is a job. This is a, I would say, terrible time-consuming job for human beings, and I think this is the point in which and this is the issue that we are discussing all the time. This is how artificial intelligence can help us. Of course, this will give us the chance for the dialogue, because after that we need to keep the Delphi dialogue between us. Yeah, what artificial intelligence will collect, it's just a presentation of some crude facts, and we have to judge, because artificial intelligence, I think it's extremely useful in doing the hard work, but we still have some problems in respect to judgment, and I believe that the judgment still have to be in our mind and in our hands. So that would be, and I think by using these new paradigms, like a kind of special GPT device and software dedicated to updates related to clinical data. This is the future, to keep up with the plethora of data that we have in our background. So I think this is the way. Yeah, you're right.
It's certainly one important point. The other is that we always have to consider, are we really running the right trials, and are we asking the right questions in the fields? That, of course, is a general epistemological question to all science, and especially when it comes to application in medicine in general. But I think by and large, over the last 10 years, we have made tremendous success in this respect. And I think the point you're making with the multimodal versus unimodal drugs is a very important one, coming closer to the biological principles of what is going on in brain repair after acute lesion. Okay, let me see. Are there any other questions? Stephanie? Any questions from your side?
Oh,
Yeah.
Good. Stephanie, great to have you.
Oh, yeah.
Please just unmute yourself. We
You have
cannot hear you.
You have to unmute yourself, Stephanie. Otherwise, we cannot hear you. No, I'm not good.
I have put my question into the question box to encourage all other participants to do so.
That's a good point.
Now, we were speaking about rehabilitation programs yesterday, and they can be very different. Are there any data on how to combine different types of pharmacotherapy with specific rehabilitation programs?
Well,
Like specific rehabilitation programs in physiotherapy or cognitive therapy and so on.
Well,
or
it
is
was
it
an
still to
advantage.
explore?
Yeah, it was an advantage, and most of the successful pharmacological studies we mentioned, the CARS trial, the campaign trials, of course, were always in relation, in some sense, to in combination with some sort of neurorehabilitation going on in parallel. I think it's probably not anymore the issue to say we do one or the other or a combination. Probably combination is always better. And even going back to Randy Nudo's and others experimental work, of course, all these interventions work better if the experimental animals or the patients are engaged in some sort of therapy. That's for sure. I think nobody will deny that. Nevertheless, yeah.
Well, it was very nicely outlined in the beautiful talk by Professor Morozanu. You promote plasticity or you promote outgrowth, but you need to make it work so that there are appropriate synapses and not some bad connections which are done. That was rather at the center of my question.
Yes.
Yeah.
Stephanie, I think this is an absolutely very valid question, because whenever we talk about somehow modulating this recovery process, we have two important threats. One is pathological plasticity, which might be, I would say, a theoretical threat, but I think by the power of data that we have, for approximately 60,000 patients in all database, we haven't seen let's say, problems related to pathological plasticity in any sense. I mean, here it's about particular developments of, epileptogenesis and things like that. Yeah, we are thinking, and some other, because the pathological plasticity has millions of facets. Yeah, it's start with the tinnitus and goes to the Parkinsonian, motor fluctuations and dyskinesias and things like that. So the good news is that we haven't seen this kind of developments, and this is very, very clear based on a huge, enormous number of patients in this respect here. I can tell you about that. And the second important threat, it's oncogenesis. When you have trophic factors and stimulating, the proliferation, stimulating neurogenesis, you always think it might be the case that, this is again very clear, and the safety is absolutely top notch, particularly because the most important component is CNTF. It's and CNTF, ciliary neurotrophic factor, it's a differentiation trophic factor. It's not accelerating proliferation, but rather accelerating the differentiation. So it's nicely, and it's even the other way around. And there are now some attempts to work even very aggressive brain cancers like glioblastomas and things, to try to force them to lower grading by using some trophic factors that are able to accelerate the differentiation, but not the proliferation. So I think this is important. But what I do believe, Stephanie, you would like to know, it's what is the protocol of kinetotherapy, physiotherapy that have been used? Yes, we have a standardized protocol, a nice protocol that it was developed by our steering committee and our advisory board, and by the advisory board, the steering committee was supervising this, of course. And it's a very comprehensive one. And if necessary, I don't want to keep too much time here. We can definitely discuss this. And this is quite, I would say, standardized. It's standardized because evidence-based is standardized. But I would rather be much more inclined to personalize. But in our attempt to accumulate evidence-based, we have to follow standardizations in order to reduce heterogeneity. And I believe in the next attempt, in the next step, to have a confirmatory large trial, will stratify better these patients, also according to the capacity of their biological reserve. If there are any other questions, Stephanie, please.
Well, let me briefly comment on this issue. What sort of physiotherapy is the best? That's very difficult to say. Basically, we don't have an answer to that. There's one way of thinking. You say, irrespective of what you do, it doesn't matter, provided you do it at the proper intensity. And the other aspect is, of course, we have to do it in a specific and learning-oriented way. For the time being, I will address that on Sunday afternoon if anyone is interested in that. It's a tough problem because really, I think we do not have the particular, let's say, mode of physiotherapy, for instance, for motor rehabilitation. We are faced with unsolved problems as proportional recovery, which occurs irrespective of what we're doing. And so it's still an unsolved question, although a lot of work has been devoted to that, and it's still devoted to that day by day. Let's say constraint-induced movement therapy, urging the system to work rather than being trapped in some learned non-use type of concept is certainly an important issue. But to be honest, over 30 years or so, we have learned a lot what we can do, but we don't have the lapis philosophorum, the stone of the wisdom yet, to be honest. say, but if you're interested in that, I will allude that on Sunday afternoon in this series again, and within the next days, also other colleagues will certainly also cover this to some extent. Okay, any other question? Let me look at the here. Yeah, there was one, two questions.
One is Stephanie.
Yeah, that is solved already. Now there are two more. One is on cerebralize and to use in subacute or chronic stroke. I think that is probably a Duffin can address.
Yeah, of course, I will explain this. So basically, as I mentioned in my talk, the best would be to introduce cerebralizing as soon as possible, because this is the most important evidence-based, to introduce the drug in the acute phase. And according to the definition, of course, it's absolutely in the immediate phase and acute phase, and we consider this acute phase according to the new definitions and what we have accumulated by our data the first 7 days. That is clear. But if we'll introduce this combination of trophic factors in the first hours, what is very interesting is that if we'll introduce this, we may have, and in combination, particularly with thrombolysis, we'll see that the rate of hemorrhagic transformation is getting lower, and the risk for having problem with the reperfusion. Yeah, I believe that it's a very important message. So the earlier, the better. Of course, if we lose the possibility to use it immediately due to many reasons, you know, the rate of thrombolysis is still modest, particularly in some areas of the world, it's a really critical situation. We may introduce in the subacute phase, because the most important part of the mechanism of action of these molecules is based on the long term. So long term means that according to all data that we have, it might be useful in the first, I would say, 6 to 12 weeks without any problem. Plasticity will be accelerated, and there are basic research studies and a lot of clinical data proving this. And this is the message of the eCompass study that I have presented. Yeah. So any other?
Yeah, there's one more question in the chat.
Post-stroke and dementia.
And yeah, post-stroke and dementia.
Yeah. That is also very interesting. In post-stroke dementia, and we are in the middle of a very robust, large clinical trial for post-stroke cognitive impairment, which has a very interesting design, assessing also the capacity to prevent and effect not only the prevention part, but also treating those who are, because it's stratified, it's a little bit more complex. But we have very good signals, and I remember there are a couple of clinical trials with these pharmacological multimodal drugs proving that we have at 90 days, if we thoroughly conduct the treatment with the appropriate dose, we have a difference in ADAS-Cog. ADAS-Cog is not so important for vascular, it's more important for degenerative, but still at that time was used, and they were able to detect a difference in 6.2 points in ADAS-Cog at 90 days, which is very promising. But this new generation of trials will come and will prove, I believe, better the real effect, because we are now very much driven by the MOCA and different batteries of tests that are dedicated to vascular cognitive impairment, and which is a little bit different, of course. I don't want to say it's totally different, because we always have these components. As component of, there is a degeneration in there, and there is a vascular component.
Yeah.
So
Well,
I think this is it.
we certainly have to be very critical about the concept of dementia, because that is a very multifaceted.
Yes.
And certain preceding strokes or microvascular disease, and all this may contribute to the development of dementia. The true Alzheimer's dementia, as Alzheimer described by 19th century, is probably a very rare disorder and accounts for 4 or 5% of what we have in terms of dementia problems. And when we look at pharmacological agents against dementia, we are stuck similar to stroke, but even more significant, in a situation that billions of dollars have been invested in finding drugs to counteract, following the amyloid hypothesis of dementia, to counteract amyloid deposition, for instance, and all of them failed. There was, just weeks ago, there is some light at the horizon, to be honest, with a new antibody which has been developed and seems to work to some extent when applied in early phases of dementia. But stroke and dementia is a very, very complicated field. And I think dementia is probably a more complicated field than stroke is when it comes to pharmacological interventions. And we can be hopefully be more successful in the world of stroke. Dementia is still an enemy in this sense, which should not mean that we should not go on working with around this problem. Okay, so let me have a look again. Are there any more questions coming from the floor? Not really. So I think we come to the end of this session. Thank you very much again, especially Duffin on his birthday. Join us.
It was a pleasure being with you today.
Stay with us. Tomorrow we will have another issue in the afternoon, same time, and rehab after stroke, with how technologies may blend in, with Katerina Pistorini and from Italy, and Namjong Paik from Korea, addressing you. And I hope it was informative for all people. Let me express my gratitude again to especially Christian, who is the guy behind the curtain making all the broadcasting possible, and to Duffin especially, as he helps us very much in the sense that we can use his beautiful group of people helping us with the broadcasting of these activities. So take care. Hopefully see you tomorrow.
Thank you very much.
Bye-bye.
Bye.